Hi all, good whatever time zone you're in today. It's great that you could join our session. My name is Egbert Sondorp. I'm from the Netherlands, and I have quite a long track record in working on health systems in fragile settings in a range of capacities in a range of different countries. And in particular, and most recently, I was engaged with the Kid Royal Tropical Institute in Amsterdam and in the Netherlands. And relevant for this session, I'm currently also the co-chair of the thematic working group on health systems in fragile and conflict-affected states, which is one of the thematic working groups under HSG. And I do hope that quite a few who are listening are already a member of this thematic working group, but if not, please check out the website of the HSG. You can easily find some more information. We will now run a session on resilience and recovering, exploring health system strengthening during and beyond crisis. That seems a very appropriate session, given the renewed interest in resilience and recovery recently, and not least, of course, including in the light of COVID-19, but also given the key themes of the HSR symposium at large. The key theme for the symposium is reimagining health systems for better health and social justice. So this is obviously relevant for a lot of countries in the world, but definitely also for the more fragile states and others, and in particular there where leaving no one behind is of utmost relevance. So let's start the session, and we have 4 different presentations, but of course I first to show you this slide on the tips on using the platform. You can briefly take a look at it, but I would try to draw your attention to the second point, that's the Q&A session. So we will have the 4 presentations in one go, and this is followed by a Q&A session. Of course, during the time that we are running the sessions, you can already start asking questions in the appropriate box that you will be seeing on your screens. And but important is that you also include the name of the one you want to ask the question to. So that makes it much easier to run the Q&A session at the end. So I think that's what we needed to get started. And I'm happy to introduce, first of all, Justine Namakula. She's a health systems researcher at Makerere University in Uganda. And she will talk to us about mapping relationships for supporting health service delivery during recovery from conflict. Lessons from formal private for-profit health providers in northern Uganda. I think it's a nice example of work which is still ongoing from a conflict which has fortunately more or less ended quite a while ago, but there's still lessons to be drawn from that era, and Justine has taken that on. She is now working for the Perform to Scale project at Makerere, but previously she also worked with the Rebuild Consortium, and that is an international consortium which did quite a lot of work on health systems research. Quite interesting. It's now being followed up by a follow-up program called R4R, but the Rebuild Consortium closed in early 2019 when she was engaged. She will present work which is related to her PhD, which she has just been finishing at the Queen's Margaret University in Edinburgh. So, Justine, the floor is yours.
My name is Justine Namakula, and I'm going to tell you about mapping relations for supporting health service delivery during recovery from conflict. And I'll be sharing lessons from the private for-profit providers in Gulu District, Northern Uganda. So first, I'll tell you a background about conflict in Northern Uganda and about service provision in that area. Northern Uganda experienced a conflict for 26 years, that is from 1986 to 2006. And during this time, majority of the public facilities were destroyed, and health service provision was dominated by private providers, in particular non-government organizations, which operated a camp-based service, as well as faith-based providers who remained open, and a few, very, very few private providers. Post-conflict period then brought in a change whereby the public sector resumed active role, and it continued to exist with the other actors, in particular the mission sector and the private profit sector. But at the same time, we understand that poverty levels in northern Uganda are very high compared to the rest of the country. And this study is trying to understand the private providers that are existing in northern Uganda and Gulu district, and what their network is, and what the relation objectives are within which for the importance of service delivery. So this particular slide is showing you the general network for the private for-profit providers. I surveyed 45, and this is how busy the network is. And this network incorporates various organizations. It incorporates universities, it incorporates regulators, it incorporates supermarkets, pharmacies within the district and outside the district. So it is quite a very, very busy network. It shows you how close-knit these people really are. And in particular, I would like to talk about what is linking these organizations with others. I sampled out a few of the organizations and tried to summarize the relation objectives. So in orange, we have those particular organizations that are mainly for referrals. We see 3 hospitals. We have a private not-for-profit hospital and a private hospital, as well as a government hospital, all very important for the network in relation to maternal services. And then we have those in green, some laboratory services as well as X-ray service organizations, which are basically important for specialized diagnostics, particularly lab tests as well as X-ray services. And then in blue we have pharmacies mainly, and these are key for pharmaceutical supplies and drugs procurement within the network. And in red, we have the office of the district health officer, as well as some district level regulators, which are basically important for coordinating the private sector and regulating it in relation to the quality itself, and also entry. And then we have those in gray, which is quite a unique one. We have an insurance company which set up a clinic to basically manage health services for all the other ones that do not have actual facilities, but also liaises with the other hospitals in the area to provide these services. And at the end of the day, it gets paid for that. And then we have in black, particular private for-profit providers who are basically in the network to provide general clinical services, a mixture of all of them. So in conclusion, I would like to note that the network for private for-profit providers in Gulu is illustrative of interdependencies between providers in that area. And this implies that for the private sector to function fully, it needs to align itself with those other players that actually offer key services in the network. I pointed out those who are doing referrals, diagnostics, medicines, and regulation. At the same time, the existence of these interdependence in the network suggests that there is need for all these actors in the network to be supported together in order to maintain the interdependence. And this will enable the providers to grow together and get strengthened in order to ensure resilience of the health system in the area. And lastly, I would like to note that there is need to rethink about flow of funding and support from government. We found that in this particular area, the government was trying to select a few of the for-profit providers to actually support in relation to having service provision extended in the area. But we need to make sure that we have all of them supported as a group, and at the same time, this will ensure that there is resilience of the health system with interdependent functions, because all of them have a clear part to play. And in an era where we are focusing on leaving no one behind, we don't have to only leave the clients behind. We also have to ensure that all the provider is also taken as a whole group, a neat group in this particular setting. And for settings that have been shocked by conflict, and weakened by conflict, the interdependencies within these particular players are very key for the sustainability and the strength of the health system. Thank you so much.
Yes, thank you so much, Justin, taking us to northern Uganda and show us all this interdependency between a lot of organizations. Very interesting to see how they all linked and needed to be supported together, as you argue. We move on. In the meantime, the audience could already start asking questions if you have to Justine in the Q&A box, and we'll address them later. But we'll first continue with our next presentation. That will be Omar Asfour. I had the pleasure recently to meet him, at least virtually meet him. He was one of the emerging voices this year. And but he's now also presenting his presentation, Destruction, Fragmentation, Rebuilding of Syria's Healthcare System After a Decade of Armed Conflict, an inquiry by the Lancet AUB. AUB stands for American University in Beirut Commission. So Omar is a public health specialist, and he works with the Commission on Syria, based in Jordan at the moment. He's a medical doctor and a public health researcher, and yeah, he has been engaged in the whole Syria humanitarian response through a lot of different capacities. He was granted a Master of Public Health from the Emory University, and he has a number of other professional certificates, as you can see. Omar, up to you to take us to Syria. So a much different stage of the conflict, not over yet, not really, but there is some things have changed. So we were wondering how you think how it could be rebuilt, or what can be done in that area.
Hello everyone, this is Omar Asfour. I'll be presenting to you some of our work with the Lancet AUB Commission on Syria regarding the impact of Syrian crisis on health systems inside Syria. Our main objective is to study the effects of war on Syria's healthcare system, and of course to identify gaps and opportunities for recovery and rebuilding of healthcare systems inside Syria. The methods we followed, we conducted at first comprehensive literature review. Now this review included all kinds of publications, peer-reviewed publications, gray literature. We included original research, reviews, field reports, and other kind of publications, everything that is relevant to healthcare systems in Syria. We analyzed territorial healthcare system according to our own health system matrix, which is a tool we developed to account for conflict dynamics and also humanitarian assistance components, as well as health system pillars. If you are familiar with the conflict, probably this would make some sense to you, but we identified, or we defined 6 main units of analysis, 6 main territories, according to the change over time in the lines of control, and also in the change in political affiliations, political support, and also accounting for geographical significance and geographical distinctions of each area and territory. Our matrix, so for each identified territory, we extracted data according to the health systems, WHO health system building blocks, governance, finance, workforce, services, supplies, and information. And also we accounted for 4 main humanitarian elements, which are coordination services, funds, and access. I'll present 2 examples of our territorial health systems. First of all, I'll present a brief about the besieged areas, health system in besieged areas. So across Syria, throughout the conflict, we had multiple areas which were militarily besieged. Access to these areas were completely blocked for military purposes. Even humanitarian access was almost impossible. So health governance in these areas were assumed by local networks of health workers, which were fragmented and I would say relatively weak. These areas, due to the restricted access, were deprived of all essential services, basic services, and infrastructure was severely damaged due to continuous violence without an opportunity to rebuild and maintain this infrastructure. Workforce was depleted and unavailable. Most of the workforce were untrained or not properly trained, not qualified. Many of de facto health workers were not actually health workers originally, or before the crisis were not health workers. We saw a lot of attempts to support these workforce through telemedicine and distance training. I would say it came with limited evidence of success. And also we saw some innovative approaches to services to compensate inadequacies in services and supplies. And of course, these came with really difficult and challenging ethical decision making. Now, another example is the Northeast Syria and the Kurdish administration. Since 2017 to present, these areas came under control of the Kurdish administration after intense fighting against ISIS. Governance were assumed or was assumed in a almost completely destructed areas. Humanitarian assistance was contested, actually still contested through and delivered through different hubs, three hubs, Syria, Turkey, and also the NGO forum in this area, in the NES. We also had significant role of, or realized significant role of stabilization funds and stabilization money, which is a political money that does not adhere to humanitarian principles. Also, many of the services were not available. In general, these were wide areas, so access was, I would say, is very poor. Traveling times is really long to reach nearest area, nearest facility, and also workforce was generally short. Surprisingly, we realized an important role of private health services within these areas, despite all the destruction and deteriorated socioeconomic status. Across Syria, we realized some cross-cutting themes. First of all, we had the emergence of bottom-up health system governance. Even though these governance models were fragmented, also sensitive to conflict dynamics and humanitarian contributions, I would say relatively all dependent on different dynamics that's happening during the conflict. Territorial health systems depend on external funds, which are subject to competing interests, of course. And again, these external funds had major influence on governance and also healthcare planning and healthcare supplies. The humanitarian contributions, as well as humanitarian failure, had significant role through advocacy, access, coordination, service provisions, and of course, the humanitarian action has never been independent or truly independent. Health system elements are inadequate, unreliable, and depleted due to the weaponization of healthcare. And of course, we are referring to services, supplies, information, all health system elements. How to move from crisis to recovery? We first need to stop attacks on healthcare, protect healthcare, and restore the neutrality and impartiality of healthcare. We need to build on the innovative and adaptive responses that emerged in various territorial health systems during and throughout the conflict. We also need to follow an integrated, coordinated investment of the currently available external funds. So it's a more efficient and sustainable investment of these funds in order to build for the future. And we need to generate more reliable and accurate evidence, establish coordinated approach to health services information, health services, health system information, health surveillance, and to account for all contributions from humanitarian actors and across different territories. Thank you so much for listening, and look forward to your questions.
Yeah, thanks a lot, Omar. This is fascinating how you could look at the different territorial areas. That's how I never thought about it, but it will be interesting to see. Of course, there's still territorial health systems probably, and how your approach, which you have, are recommending, will be relevant for all of the current territorial health systems, or maybe less or more. Again, if you have questions for Omar, please post them. In the meantime, we will listen to Samuel Lordimes, who is currently a research fellow at the Center of Health Economics in York. And he will take us to a very different part of the world, again, to Colombia, and we'll talk on re-establishing effective health systems governance after conflict, the health care provision in post-accord Colombia. So this is an area where conflict may still be looming. There's still elements, definitely, as we hear in the news, but there has been an accord 2 years ago or so, and Samuel is examining what happened in terms of governance and demand for services and another of other aspects. So please go ahead, Samuel. We'll listen to you.
Thank you very much for attending this presentation. So the title of this work is Reestablishing Effective Governance After Conflict, Health Provision in Post-Accord Colombia. This is a joint work between Nina Kaspersen, Urban Jaksha, Rodrigo Moreno Serra, and myself. And this work is funded by the Medical Research Council. So we attempt in this paper to analyze the effect of the 2016 Colombian peace agreement on health services in areas with both high conflict intensity and sustained rebel presence. The Colombia 2016 peace agreement promised to improve public provision in conflicted areas, included better access to quality of healthcare. However, we know very little about the challenges that such re-establishment of effective government faces following such a long conflict. So our research question addressed this gap in the literature by effectively asking what was the effect of the peace agreement on the availability and quality of healthcare in conflicted areas. We try to identify the key obstacle to re-establish the state's presence and ensure public service provision. And we also explore the perception of public healthcare provision and compare it to rebel provision. We use a mixed method approach in this analysis that relies both on a quantitative and qualitative analysis. So with the quantitative analysis, we explore how healthcare demand and quality of healthcare change with the peace agreement, the 2016 peace agreement. So we are focusing this quantitative analysis on the meta department. So the meta department is the red region that we see on this Colombian map. So this meta department was chosen because the region has been affected by the armed conflict from an early stage, but it also has various degrees of persistence and intensity of conflict or violence across its 29 municipalities. So we exploit this variation in a difference in different strategy that compare the main outcome, healthcare demand and quality of healthcare services before the peace agreement. So we have data on 2014 and after the peace agreement from the data in 2018. And we use a set of control variables that include the FARC presence and the state presence. We also have this qualitative analysis that relies on interviews and focus group with nurses from reintegration camps of ex-combatants. So reintegration camps are specifically targeted for improved healthcare. Unlike the other healthcare provision in Colombia, these services were run directly by the Colombian Ministry of Health. And we also have 12 focus groups with trainees and teachers of the health peace of the Health for Peace program from the International Organization of Migration. The trainees were all from rural, remote areas in different regions of Colombia, and they have therefore experience of the challenges for accessing healthcare in rural areas, both before the peace agreement and after. The quantitative, so the finding with the quantitative analysis is that the peace agreement effect are relatively small and negative in municipalities with FARC presence, and they are also negative and small with municipalities with state presence. And we also do not find any statistically significant effect on the perception of healthcare quality. With the qualitative analysis, the results are more contrasted, but we saw no improvement, or even many saw no improvement or even negative effect. Even negative effect, but we also find that areas around the reintegration camp have the highest positive effect. So from this result, we try to identify three main mechanisms. The first one is the delays, obviously, in re-establishing effective state presence. We also have the comparison with healthcare provided by the FARC, which might have been of various degrees of quality and availability, and also high expectation combined with mistrust of government provision. So in conclusion, we highlighted the challenges of reestablishing effective governments in such a long conflict. We show that the degree and form of rebel governments are important factors that impact the post-war recovery. Our finding also suggests that conflict areas cannot automatically be assumed to be ripe for better governance because of possible delays in establishing state presence and the high expectation that prevails in these regions. So it can result overall in increased mistrust in public services, lack of demand, and even negative perception. So thank you very much for your attention. And if you have any question, please let me know.
Yes, thanks a lot, Samuel. Again, a very different context, and intriguing to see what happens after such an accord. Very different type of conflict, much more low intensity summit, but also in the faraway places, which makes it all probably more difficult also for a government to re-enter. Again, if you have questions for Samuel, please post them. We are now moving on to our final presentation. It's another example of all four of them have been working hard probably for many years and wanted to present their research, and it's a challenge to combine that in condense that in less than 10 minutes. But Sakif will try again from take us through a whirlwind of his research on fragility to resilience, assessing opportunities, analyzing challenges, and monitoring progress in Liberia's health services. But as you will notice, it will even go beyond Liberia, what he's trying to study. Sakif is from Bangladesh, but he is currently more in Europe. He's working as a consultant for WHO in Geneva, but in particular also a PhD researcher at the University of Edinburgh. So please go ahead, Sakif, and with your story on Liberia.
Good morning, good afternoon, and good evening, everyone. My name is Sakif Mustafa, and I'm doing my PhD research at the Global Health Policy Unit at Edinburgh University, where Dr. Mark Hill is supervising. I also work as a consultant at the WHO in Geneva, the Health Services Resilience Team, which is led by Dr. Sohail Shaikat, with whom we've worked closely on a research program closely linked to the topic of this presentation. Over the next few minutes, I'm going to take you through aspects of our work, focusing on health services in Liberia in the context of successive health emergencies and Liberia's journey towards building a more resilient health service and how this is being deployed in the context of COVID-19. Although there are many ways to define health systems resilience, it's essentially the capacity of the health system to prepare for and effectively respond to crises, maintain core functions, and informed by lessons learned, reorganize as required. The interplay between the key health service resilience capacities, the emergency management cycle, and the health system's building blocks is visualized in the picture in the middle. It's important to note that these are not specific phases and they're not distinct, they can be overlapping. The resilience of a health service is intricately linked to the wider health system and its constituent parts. WHO's building blocks framework is a useful and simple way to see how leadership and governance, workforce, financing, and so on the right-hand figure are enablers or determinants of health service delivery. Liberia is a particularly interesting case study in exploring how health services progress towards resilience. It has had a history of brutal civil war and critical foundational gaps in its infrastructure and health system. A decade or so after the civil war, the 2014-16 Ebola outbreak hit. During and following Ebola, significant external and donor investments were made, as well as the introduction of several policies, legislation, and plans, such as the investment plan to build a resilient health system and the development of a new National Public Health Institute, which is underpinned by national legislation. Nevertheless, resources remain constrained, economic contractions occurring, and this has serious consequences for health service provision. All these factors are likely to contribute to Liberia's handling of COVID-19 and future outbreaks. In this research, we're interested in why and how these factors have affected the resilience of the health service, and we use the resilience definition to address these questions. The work presented here is part of a wider program of health system strengthening and resilience building activities led by the University of Edinburgh in collaboration with COMAS in Sierra Leone and the WHO Country Office, national partners such as the NPHIL and Ministry of Health and WHQ. Building on knowledge, evidence, and activities from a Korean funded project, a COICA funded project, and as part of a UK NIHR's National Institute of Health Research Development Grant, we're interested in exploring how the concept of health services resilience can be defined and operationalized in the context of Liberia, and how our understanding and approach to defining and operationalizing health service resilience has evolved due to COVID-19. Our approach to this research and program of work started with a systematic review of relevant literature, followed by analyses of key documents, triangulated with findings from interviews, and continued dialogue with key stakeholders. This formed the basis for coming up with 4 key capacities of resilience. We then undertook a range of semi-structured interviews pre-COVID and in Liberia during COVID. We continued our dialogue with key stakeholders in Liberia during the COVID-19 period, in which national response to the outbreak, including a national lockdown, occurred. In addition to this, we conducted a range of key informed interviews with stakeholders in WHO, World Bank, Ministries of Health, and the private health sector in a range of low and middle income countries in which COVID-19 and the responses to it had reached a more mature phase than was the case in Liberia during this data collection phase. Our findings and analyses are a synthesis and triangulation of this data from across multiple sources. Looking at the impact of Ebola in Liberia, in addition to the high number of cases and mortality caused by the Ebola outbreak, which you can see in the figure on the top right, there's a wealth of empirical evidence that indicates significant declines in health service utilization in 2014 versus the same period in 2012 and 2013. This tells us something, that the traditional assumption that outbreaks lead to solely demand surges is not quite right. There's a higher demand relating to the specific disease, but also offsetting reductions in demand for other things. The overall impact is complex, but there's clearly a risk that while the health service struggles with the specific disease, it neglects other aspects of service provision, and this is likely to have an impact on excess mortality well beyond what we can directly attribute to that outbreak itself. These declines in service utilization are explained as partly due to temporary closures of facilities and partly due to the community's mistrust of the health service, with the result that they were reluctant to attend health facilities for fearing, the patients are reluctant to attend health facilities for fear of contracting the outbreak-specific disease, with limited access to public health facilities, which are normally free. Out-of-pocket spending increased due to the use of alternative and private health facilities, further limiting access to services. In the true graphs in the bottom left of the slide, we can see that there's a 61% reduction in outpatient visits, and this was the case across all administrative areas and counties within Liberia. From the graph in the bottom right, we can see that there were significant declines in service utilization for essential maternal and childhood services. However, on the last graph in the bottom right, we can see a sharp increase in measles vaccinations that occurred around December 2014, which was a result of an accelerated campaign by the Liberian government in support of WHO, the US CDC, UNICEF, and other partners. Key challenges were mobilizing quickly and before the onset of difficult rainy season when roads became impassable. The effectiveness of this intervention was driven by an integrated and timely approach incorporating multiple stakeholders, being locally focused and engaging the community. Overall, though, these disruptions led to reversals and gains made during the periods of relative peace post-Civil War. Furthermore, the economic consequences were severe and well documented, with significant impact on health service provision and health expenditure and so on. And finally, a lot of the external and donor support focused on verticalized and siloed initiatives rather than building health services and system-wide capacities. So a lot of these capacities were not institutionalized and didn't lead to longer-term health system strengthening, which have had an effect on the management of COVID-19. There's limited empirical evidence on the impact of COVID-19 and disruptions to health services in Liberia at this stage of the pandemic. Nonetheless, we've identified from existing documentation, ongoing interviews, and other forms of communication with colleagues in the country that there have been changes in the supply of health services. There have been facility closures, including diagnostic centers, and a temporary closure of the largest hospital in Liberia because of 2 maternity health workers testing positive for coronavirus in mid-April, and the facility requiring disinfection. Routine immunization programs have also been disrupted. On the demand side, patients aren't presenting to health facilities for a number of reasons, some of which are similar to those from Ebola times, such as the national lockdowns from April to May, which have consisted of daily curfews, bans on movement between counties, and the closure of all non-essential businesses. This has reduced mobility and reduced household income, and therefore the ability to pay for health services. There's also prevailing fear of catching coronavirus, as well as a sustained level of community mistrust in health services. Furthermore, diversion of the health workforce to focus on COVID-19 has led to disruptions in other key areas, such as malaria and maternal and child health, and global disruptions to supply chains and access to medical equipment, such as ventilators and so on, is also a contributory factor. This is a modeling study from the Global Financing Facility that shows what the current coverage and coverage, if services are disrupted, could lead to in terms of health outcomes. And the overall impact in the table is illustrative of the wide range of disruptions that can occur in terms of health outcomes. This could lead to a 30% increase in child mortality and a 15% increase in maternal mortality over the next year. The evidence also suggests that the breakdown in primary care provision during an epidemic can lead to longer-term increases in indirect morbidity and mortality. Given our objectives to understand how the concept of health services resilience can be defined and operationalized in the context of Liberia, we framed the crucial capacities of health services resilience as outcomes and articulated strategies as part of our program of work. This is a summary slide which highlights some of the key health service resilience requirements based on our data collection and ongoing dialogue with experts at WHO and in country. I won't go into the detail for each of these columns, but I'll highlight those especially relevant to addressing the problems of supply and demand side reductions in health services due to COVID-19. For example, a key determinant of resilience is the availability and access to required funds and structures and resources that enable the health service to communicate with communities and provide essential health services. In terms of process, this includes promotion of essential health service utilization through risk communication and community engagement. The outputs we'd like to see as a result are that contingency funds are accessible, risks are well communicated, and communities are engaged. This would all contribute to the maintenance of essential health services and thereby reduce excess morbidity and mortality. This slide summarizes our approach and observations in the context of COVID-19. From our study, we came up with 4 key capacities outlined in the blue box on the right. Largely, we can see that capacity 3, the absorption, adaptation, and response to increase in demand for emergency-related health services was maintained well. But capacity 2, maintenance of delivery of routine and essential health services delivery, has not been maintained, done so well. This diagram serves to illustrate the social, economic, and health service impacts of infectious disease outbreaks and their interplay. The key thing to note is that healthcare service delivery and the public health response further exacerbates the supply side and demand side determinants of essential health service utilization. And these are further compounded by the socioeconomic impact. So solutions are likely to be a combination of mitigating the factors which lead to supply and demand side disruptions at the individual and population health level, but they will also need upstream structural interventions. So as alluded to earlier, our research focus has evolved in the context of COVID-19, and we think that future research in this space should look to the empirical impacts of COVID-19 on access to routine and essential health services, including medium and longer term impacts and health outcomes due to disruptions. And we've listed these here. In our program of work, we will continue this inquiry focusing on Liberia, and these are the sort of key questions that we're now looking to answer. Sorry that this has been an absolute whirlwind. Thank you all for your attention and time, and thanks to all the colleagues that made this work possible. I'd be happy to discuss and take any questions and feedback. Thank you.
Thank you very much, Sakif. Very interesting, of course, to do studies these days in Liberia with the Ebola and now the COVID and what they have been learning on it and how this can be addressed and then expanded to other countries with less of that experience in the past. So it would be interesting to hear a bit more about this maybe later on. We will now starting our Q&A session. We have about half an hour, and I think my colleagues, presenters will show up for you to become visible. Still waiting for one more. And yes, there they are. So as you may have noticed, of course, these were pre-recorded sessions, which of course is quite a challenge anyway, I suppose. And you now have to have gone through the ordeal of having to see yourself and listening how you were doing. Personally, I think you all were doing great. It was indeed a whirlwind, and that's the nature of this kind of studies. They come up with so many aspects, and of course you would love to capture them. So let's move on to our questions, and there's definitely scope for some more questions. I have a few here, and I'll start with Justine. But please, anyone out there in the audience who I can't see, obviously, but I'm sure you have questions for the various presenters. So as again, we have about half an hour, so there's definitely some scope to go into some aspects a bit deeper. So I assume you also see the questions. So yeah, Justine, you have this questions from Helen Schneider. It says you outlined a form of network governance in northern Uganda held together by interdependency. What role can the state meaningfully play in strengthening such a network when the local authority appeared to be such a peripheral player? Justine, could you?
Like I said in my conclusions, the state has to come up and support more of the players, because right now they're only supporting a few of them. And it means that the network is quite imbalanced in relation to state support. So they need to support more of them. Currently, they're supporting a few of them with subsidies for vaccines to increase coverage for immunization. But if they could increase that to many others, that will also create more trust from the other side.
Thank you, Justine. Is it true that the government is such a peripheral player in the north, or is that?
Right now, the government, after the conflict, like I said earlier, the government is coming back to the center of health service provision, but we find a mix and match of all these other players acting within the same space. So they're trying to compete for, what can I call it, advantage within the same population. But you find that in most cases, the private providers are situated around the town itself. And of course, it has all influences to what happened during the war and how people were able to transfer during displacements to the town, urban area. So we only have right now in Gulu district, we have one government hospital, and all the rest are within that municipality. So almost trying to crowd it out with all the various mechanisms, but it's struggling in there and it's coming back, building up more capacity of the pharmacy area, building up the infrastructure, and we hope for the better as time moves on.
Yeah, no, thanks, Justine. Highly complex, and then you have also the non-for-profit sector, which of course is out there still as well, I'm sure, and there are many there. I know them. I've been there. Yeah. So Yeah, let's move to Omar. There's a question from Melanie, and there's a question from Jana. I think you could answer both of them. Let me read them. How to approach system strengthening in Syria with such a fragmented system in terms of geography and a range of state and non-state governance actors? Yes, challenging. And could you speak more about how you will use the different categories of territories? Or are you recommending different approaches for rebuilding the health system in besieged areas versus other categories, for instance? Yeah. Omar.
Well, these are really good questions. The main point about the Syrian context is it's really a very dynamic context. So this fragmentation actually has kept changing over the time. So when we focus on fragmentation, I tend to think of this fragmentation in two ways. The first way, it really helps us to not plan, I wouldn't say plan for health system strengthening on the long term, but actually inform our humanitarian priorities as humanitarian practitioners, as humanitarian partners. We really need to keep these differences in mind when we plan our activities in different territories or within different territorial health systems, because needs are different, context is different. I mean, there are a lot of different things to account for. But on the other hand, I mean, for us as humanitarians practicing in Syria, what is really important about understanding this fragmentation is to ensure, or at least make sure, that we have some sort of continuity of services or continuation in services. Now, what we really saw in Syria over the past 10 years is we have, I mean, the lines of controls kept shifting all the time, sometimes at very high speed. Within just few months, the lines, I'm sorry, keep shifting through wide, actually, geographical area. The main issue in this, when these lines of controls were shifting, is that, you know, this affected area, every time we have someone new in control over these certain territories, we build from scratch. Political parties did not coordinate, did not collaborate, they did not talk to each other, they did not preserve some sort of neutrality for healthcare. So, and in certain areas, actually, healthcare facilities, primary healthcare centers were actually the first military targets when escalation violence happens. So when we highlight this kind of fragmentation or trying to understand this kind of territorial healthcare system, actually, we really need to make sure that we have some sort of understanding and try to make sure that, okay, we have, I mean, in these territories, we have some strengths. So regardless of the fighting, when someone new is here, we really need to build, to invest in this. Now, of course, I mean, on the longer run, we really need to, again, I mean, we are seeing this right now. So, for example, I think in the question, one example emerged, one example was about the besieged area. So we didn't have any besieged area since 2018. So this is almost 2 years now since the last besieged enclaves were not besieged. But till now, we still hear reports from the field, from our colleagues inside Syria, health practitioners. We know that these areas that once were besieged or under certain, political control, now they are neglected. And this is, I mean, all this comes under the term of weaponization of healthcare. So we use this term a lot. Healthcare has been weaponized, used as a weapon. And part of this weaponization is actually in these areas that once was not under the political control of X or Y or the current, political affiliation and power or whatever, are being neglected and somehow being punished. And actually, we saw this. We can say that in the current COVID-19 pandemic or crisis, it really can tell. I mean, the areas that were once besieged is extremely neglected. So again, I mean, when we highlight this issue, we really need to try to understand how things stand in different areas. And when we plan, I mean, it's about informing planning for the future. And again, I mean, as I mentioned in my recommendation, we really need to restore neutrality, maintain, protection of healthcare, make sure that healthcare is outside this kind of political contention, and make sure that, again, I mean, it's all accounted for. But honestly, I mean, we can't really talk, or we don't really know how to talk about health system strengthening, like exactly health system strengthening in a traditional sense, within this still active conflict and dynamic context, where every day we are having a new challenge and a new change in the context.
Yeah, thank you, Omar. Yeah, it's tough to work when things are still ongoing, but as we also see in the case of Justine, they will in there for the that's for sure. That's kind of lessons which we see all the time, that it takes so long to, once things got disturbed, how long it will take to build it up. I have seen some questions coming in for, and I still have to get the right spelling. I think Sakif, yes. But before giving you the floor, Sakif, you can look at the questions. And I think the no is on in Lisa's questions. But I have a question for Samuel in the meantime. Samuel, you have, of course, about the new governance in the previous FARC areas, which are now kind of controlled by the government. I assume, and I think that's what you kind of implied, that the FARC also did provide health services in the days that they were in control of those areas. But then, overlooking your study and see what you found, because you see, well, there's not much change, but you kind of seem to imply, hey, the government should be doing a bit better because they are mistrusted anyway, and it might be a good soft power or whatever you call it to have better health. What is a kind of key recommendation which would follow from your study to the government?
Well, yes, thank you, Egbert, for this. So we did find, I think, three main things which are: first, there is a delay in establishing state presence in some areas, and we also find that there is a favorable view actually of healthcare which was provided by the FARC, by the rebel combatants before the peace agreement, and we also find a mistrust in government. And so what it seems to be is that overall the expectation from the people, from the local population to see the state coming in is very high. And so obviously it takes time for the government to set in, but at the same time there is really a large expectation. The demand might be very high as well. So there is definitely a very important focus that needs to be addressed on this specific region that were occupied by the rebels, and this is particularly true in some of these areas that were completely left by the government. So the situation is difficult for the government, but at the same time so it takes time, obviously. But the expectations are very high. Yeah.
Oh, thanks, Samuel. Sakif, your questions are quite different, so take them one by one. So first is this question from Tim. What were the issues relating to donor coordination, and were any of these addressed?
Well, thanks, Egbert, and thanks, Tim. That's obviously an excellent question. So Liberia's history with the history of civil war and conflict, that was really sort of the backdrop for where all the lack of capacity for the health system, the lack of capacity across the government, and obviously a whole host of NGOs, international organizations, USAID, WHO, etc. They all occupy quite a long-term base within Liberia, and they're supporting and stopgapping a lot of activities. So I think the main thing that's kind of emerging from across our presentations is that integrated approach that you need, particularly at the core of resilience of health services, the ability to maintain those essential health services. So how that's sort of our end goal. To do that, we need this integration, and us as all relatively quote unquote external people that are coming in to try and understand what's going on and provide our support. I think it's really important to address that issue of duplication of activities, the issues of replication of activities, and also sort of donor dependency longer term, which was a real issue. Post-conflict, there was significant investments made, capacity started to build up. Then we were hit with Ebola. Capacities dropped across the health systems, building blocks, or however you want to conceptualize it. Investments were made again, but these weren't sustained into long-term capacity. However, what we're trying to understand with this research is which specific capacities were maintained, which investments did have the greatest impact in terms of health outcomes, but also those sort of intermediary steps in terms of specific healthcare provision at the different levels of care. Things like immunization, malaria programs, which ones were the ones that were sustained. And what we already know from the theoretical literature and some empirical evidence is that those interventions that really backstop and support the government's capacity, the Ministry of Health in the middle, those are the ones that generally sustain. So I think that's, it's a very difficult question to answer, but those are a few of my reflections on that one. Thanks, Tim.
Yeah. Thank you, Sakif. If there's anyone out there who still would like to ask another question, there's still some space, don't hesitate. But in the meantime, Sakif, could you look at the question of Lisa was posting? Is there any evidence in Liberia of mitigation of the impact on primary health care in community health workers' delivered areas of work?
Oh, thanks. Another excellent question. So I'm just trying to understand, is there any evidence in Liberia of mitigation of the impact on primary health care in the community health worker? So there's evidence of widespread disruption caused by both Ebola and COVID in Liberia. Empirical evidence, quite qualitative. What we're trying to understand is the perceptions of key stakeholders that are working on the ground. There's a wealth of experience that's been built up due to the history of what Liberians went through. So there is evidence of impact across health services, specifically to primary healthcare. I think I touched on immunization coverage has went down. Other partners are reporting that if we don't step in or have a really focused and targeted, sustained long-term plan for maintaining immunizations, malaria campaigns, vaccines, and then obviously the so-called dual threat of rising NCD, disease burdens, and so on and so forth, and preventative care, then of course that's a huge problem. But certainly from my general understanding, yes, there's impacts across health services of any of these sort of crisis events, and we really need to, in a targeted, systematic way, figure out how we can support the Ministry of Health and allied partners and ministries in maintaining those community health worker driven initiatives, because we know that they are the ones, those are the most effective, particularly in the context of mistrust and so on. So hope that goes some way to answering the question. Thank you. Thanks, Lisa.
Thanks, Sakif, yeah, it's always unfortunately we don't have an immediate way of interacting with the ones who ask the question or any follow-up questions, so that's it's not so easy. So again, if there's anyone out there who asks a question, but if not, then I still have quite a few questions left, which some were already answered. But I have a question for Justine. Looking at your presentation, I was intrigued. Where, in fact, does your interest come from to study the for-profit sector? Because it's a topic which is at debate in various. We had some recent webinars on the topic as well. But why did you specifically focus on that subsector? Was the interest coming from? And then maybe you can explain a bit. You don't have to go into extensively, but in your methodology on how do you do this mapping? How do you decide on define the degrees, as you have shown in that other graph, the various degrees between agencies? That's probably you do this through interviews or questionnaires. Just curious how you actually do that.
Thank you so much, Egbert. Why the private for-profit sector? So like I indicated earlier in my presentation, this PhD was an outcome of the Rebuild Consortium with which I was working. So it happened for two reasons. It happened that one, Rebuild was already focusing on the various interactions of providers, the PNFP sectors and the government sector. There are lots of studies that compared the two, in particular for health workforce incentives, as well as some issues to do with health service seeking in Gulu. So in there, we found that many of the people who are in Gulu district over time tended to seek for services for the private for-profit sector within one of the studies. But at the same time, because I was always in Gulu and going to Gulu every other time, I was quite attracted by the numbers of the private sector. Every time I walked on the street, I found a private sector shop or drug shop or clinic or hospital, and I kept on getting interested and asking myself, what is it that makes them survive in such an environment, given that there was conflict, at the same time the population is relatively poor, as I indicated in the beginning, compared to the rest of the country. So I was quite intrigued, and the comparison about trying to contribute to information and evidence about recovery within Rebuild Consortium then attracted me to match these pieces up and see how these particular providers survived over time. So basically my study in general was looking at their experiences as a sector, but at the same time, how they contribute, in addition to the other two sectors, the private, non-for-profit, and the public sector, to the overall system resilience and recovery. And of course, given the fact that there was this, over time, there came this debate about UHC, leaving no one behind, and all these generic statements about the private for-profit as being providers that rip off the poor. All these in the context kept on making me get heated up within the study over time. But then you ask the question, how did I do this particular study? So it has a twist. So within Rebuild, we had used some interesting methodologies. So we had used life histories to understand how health workers had experienced conflict and how they coped. So I wanted to use this particular experience to study organizations. So these are organizational life histories over time. So from when they were set up, so some were set up before the conflict, whereas others were set up during the conflict, many of them during the conflict, and then a very few were set up after the conflict. So I have a trajectory of those. And of course, if you check them individually, the networks of those ones change and are different. So the ones that have stayed in the area for some time have a bigger network and a stronger network if you single them out individually than the ones that have just come in. But of course, given the fact that they're all competing in the same market, there are those that market themselves way much better than others, and they keep on lobbying for support from the government and other providers, trying to get all these linkages. So those who have thicker networks. So I use organizational life histories. Those are qualitative interviews. and I used key informant interviews. At the same time, I had a survey, an organization survey. So all in all, I had 60 on the list, the sampling frame, I could say, because like I said, the regulators are part of the forefront of this in the network. So I went into the district health office and I asked them for the list of the providers they have that are registered. So when I say formal means those that are registered and appear on the list that is held by the district, so they can easily follow them up. And then I looked at those, but of the 60, only 45 accepted to participate in the survey. So I kept on, I used Atlas TI first of all for the qualitative, and then I extrapolated some of the summaries and put them into Excel, and then I used social network analysis to analyze and come up with these network maps to find the degree of centrality within the different providers. And so over time, I can say I've learned a mix of methods, although previously I'm a social scientist who is very, very qualitative. And here I am joining in with a quantitative and trying to explore a complex topic, which is the private for-profit sector.
No, thank you, Justine. Just to give us this glimpse of how you reached to those fabulous slides you showed us with this fantastic networks, and then try to draw some conclusion from it. I think we're going towards the end of our session. I have two small questions left, which I would like to pose, and then we'll stop. The one is to Omar. You have been doing your work in the context of the Lancet AUB Commission for Health in Syria. Could you tell us a bit about what this commission is about? What do they do? Because I've seen different aspects of it. So just a big background to the work of the commission.
Oh, thank you so much. So the Lancet AUB Commission, of course, it's a Lancet Commission, commissioned in collaboration with the American University of Beirut. And the main topic is actually to document the impact of the Syrian crisis on health. Well, I'm probably not the best person to present the full scope of the commission. But my understanding is that the commission is actually following a reverse approach somehow. So instead of focusing actually on the main topic and start with writing the full report. Actually, the full report is about to be published, but I think, it was commissioned late 2017, and they started with the small projects trying to document different aspects of the impact of the Syrian crisis on health. I was focusing on the health systems part, and again, the main objective was to document how the conflict impacted health system, and came up with the territorial health systems. Of course, we are practitioners, and it's for us, we know it's there, but we didn't really see anyone who's trying to document this. So of course my work contributed to the commission work, and there are also different thematic groups under the commission who try to contribute to the full scope of the report. So well, I'm not entitled to disclose any information, but hopefully the final report will be there soon, and it's a full report exploring the full impact of the Syrian crisis on health inside Syria, not just the health systems, also the humanitarian part, the linkage with other sectors, and again, also the status of health, and how the conflict impacted the status of health in Syria. So yeah, hopefully you will get the report soon, and you get to see the full, to read about the full work of the commission.
Thank you. I assume they will be published through the Lancet, but no, we're looking forward to it, and that's an easy, I'm sure will appear on our screens. Samuel, there's a question for you coming in from Sarah. What was the role or position of international national partners in the rebuilding of the health system? Could you say something about this?
Well, we don't. It's a good question, but we don't have. So the way we conduct this analysis is through quantitative and qualitative method, and so we didn't have any specific tools to answer this question. So the implication of the result are largely, I guess, attributed to the action of the government. And I also feel that the international has had more at this time a role of mediator for the peace agreement rather than really a real role of intervention into the post conflict. But that's an interesting question. Thank you.
Thanks, Samuel. Yes, that's yet another aspect of the study. So one final short answer, Sakif, because that's what is most topical these days. We're all talking about COVID, and you have been including COVID in your study. So what intrigues me, I think you are still continuing the study, and you say, well, you was a bit more, but is there one or two specific things which Liberia has learned from the Ebola period, which have made them a bit better prepared now for dealing with COVID?
No, absolutely, and thanks, Egbert, and thanks, Jana, for the great question. Yeah, I think that's the absolute heart of what we're trying to understand is exactly that. If I can pull out two things, not by any sort of prioritization or in any systematic way, the two things that jump to my mind. One is the establishment of the National Public Health Institute, and there's definitely lessons that we can learn from that, and that's real capacity building in action. There's some fantastic people working there, and there's some fantastic capacities that they've built up across the public health implementation measures, whether that's infection prevention, control, training, research. So that, I think, is central, and keeping them central is key as well. So that's one, and the fact that that was also underpinned by legislation, underpinned by political will, and with sort of, at the time, significant plans for financing and its operations, and like a 5-year plan. And that links to the second thing, in these sort of contexts when capacities have been so reduced because of all kinds of factors, but predominantly driven by the crisis itself, you have to start with planning. And obviously from that stems, within the planning, you want to have the political will, you want to be able to bring everybody around the table, going back to that theme about integration. So that the second thing would be the investment plan for building a resilient health system, which brought all kinds of different aspects across, not just across public health, but from outside of health, clinical services, veterinary services, One Health, the climate dimension, all of that, bringing all of that together in a solid investment plan led by the Ministry of Health, putting them at the core with political backing and investments and a long-term sustained strategy. Those are the things I think that we began to learn, and that's what will serve as well for COVID and beyond. Thank you.
Okay, thanks, Keith. I do have the feeling that you will come up with a lot of lessons, and I'm sure we can learn something here in Western Europe, how to deal with outbreaks like that, also from that, what happens in those countries which you are studying. Yes, this is, we have come to the end of our session. So I would like to thank you all. We probably get a thank you for attending this session slide. So yeah, thanks you all. I enjoyed very much your presentations. They were all full of information, and I hope that those who have listened could capture some. The big advantage is, if you're interested in, I've said I may have missed it because it was all going quite quickly, you can always look back at those sessions once they get posted. And of course, I'm myself very much looking forward, because all of your presentations will still result in work to come and work to be published. So, and not only the Lancet ones, but also the other work. I'm sure we will see more of it in our various journals. So really looking forward for you to produce that kind of work. So yes, so thank you for joining this session, also to the audience, and I do hope that you still enjoy this session, but also follow-up sessions, which are still to follow in our overall symposium. Thanks for all.
Thank you.
Bye, everyone.
Thank you so much, everyone.
Yes, bye now.
Thank you, Pat, for the moderation. Bye.
Bye now. Bye.
Bye.
Thank you.
Bye.
Thank you, Egbert. Bye.